Hello, my name is Cameron Sabat, and this is Cutting to the Case with the Dr. Richard R. Iorio. He is a nationally recognized leader in adult reconstructive orthopedic surgery, specializing in total hip and knee arthroplasty as well as revision joint replacement. After earning his undergraduate degree in biochemistry from Harvard University and his medical degree from Boston, he completed his orthopedic residency at Hahnemann University Hospital and fellowship training in adult reconstruction at Columbia Presbyterian Medical Center. Over the course of his career, he's held major leadership positions, including Chief of the Division of Adult Reconstructive Surgery and the Dr. William and Susan Yaffe Professor of Orthopedic Surgery at NYU Langone, Director of Adult Reconstruction at Lehigh Hospital, and former Chief of Adult Reconstruction and Total Joint Arthroplasty at Brigham and Women's Hospital, where he also served as Vice Chairman of Clinical Effectiveness. A prolific academic with more than 350 peer-reviewed publications, Dr. Iorio has been a driving force in advancing evidence-based arthroplasty practice and shaping health policy at the highest levels. His work is focused on optimizing outcomes through registries, bundled payments, and value-based care models, as well as addressing disparities in access and surgical results across diverse populations. He served on leadership committees for organizations including the American Association of Hip and Knee Surgeons and the Hip Society, and he's on the presidential line of the Knee Society and a board member. And most recently, he stepped down from his clinical duties to take up the mantle at the Food and Drug Administration as principal medical advisor to the commissioner. His career represents a blend of surgical excellence, health economics expertise and policy, and dedication to training the next generation of orthopedic surgeons. Thank you, Dr. Iorio, for joining our podcast.
Thank you, Cameron. This is a great opportunity. I appreciate it.
Absolutely. And I wanted to start out with you were one of the earliest orthopedic surgeons pushing bundled payments in joint replacement. What did you learn from those early CMS pilots, and how do you think they've reshaped arthroplasty practice today?
That's a great question. The interesting thing about bundle payment was even though it was only restricted to a small number of fee-for-service Medicare patients, the discipline that we learned in treating those patients has affected all of arthroplasty care. We started at NYU in 2012. The first iteration, we learned that you can't care manage your way out of poor patient optimization, difficult health status situations, or poor socioeconomics, that requires real work. And that if you operate on unhealthy patients, you get less than optimal results. As a result, we learned about surgical optimization and preoperative optimization and how to get our patients in good shape to have surgery. We also learned that we could optimize the way we delivered care, better blood management, TXA, regional anesthesia and better anesthesia management, decreased opioid consumption. All of these things together led to a much more efficient delivery of care. And then in the later teens of 2000, we entered the outpatient arthroplasty aspect, which has revolutionized the delivery of total joint replacement care to the point where you can walk in the morning with a bad knee and walk home at night with a new knee and be off and running in a pretty healthy environment. So when you look at the cost of care when it was initially delivered in 2012, we've probably cut the cost of care in two-thirds by today's dollars, which is an enormous accomplishment. And I think orthopedic surgeons can be proud of the way they've responded to this. The bundle payment program for total joint replacement was one of the few that actually produced cost savings for CMS, and we've been applauded for that. All of the surgical disciplines did much better than the medical disciplines in a bundle payment environment.
Absolutely. And, at NYU Langone, I mean, speaking of looking at the data and determining how they perform, at NYU Langone, you helped build one of the most data-driven joint replacement programs in the country. What structural or cultural changes were most critical to scaling that kind of outcomes-driven system?
So Joe Zuckerman and Joe Bosco are visionary in terms of delivering data-driven orthopedic care, as well as orthopedic education, for which they're pioneers. Dr. Zuckerman realized that their Medicare costs of delivering care were extremely high. New York was a great place to institute bundle payment because any cost savings at all was going to be magnified because the costs in New York were greater. So we had a huge opportunity, and as a result, our our victories were more strong than you would have thought in lesser markets. So Dr. Zuckerman and Dr. Bosco were committed to data acquisition. They were early to the PROMs program. They spent a great deal of money collecting PROMs on every patient that walked in the door. They were very committed to providing the resources necessary to make a bundle payment program successful, which includes preoperative evaluations of the patient, care management involvement throughout the 90-day episode of care, and giving me the opportunity to have a final say on which implants were used and which patients were optimized sufficiently for surgery so that we didn't just operate on everyone that walked in the door. We actually tried to improve their health status. And we were very successful at that.
Yes, yes, absolutely. And really that ties in very well with your work. You've been deeply involved with the American Joint Replacement Registry as well. And I wanted to know, what do you see as its biggest current limitation, and what would it take for registry data to truly change clinical decision making at the bedside?
Great question. One thing we have not done is use the PROMs as the sixth vital sign. Um, Very few clinicians use the PROMs on a day-to-day basis with their patients to influence their care. Once we do that, and once the PROMs become integrated into our quality reporting, which they are currently beginning to be with the reporting requirements of CMS, and once those PROMs are incorporated in the registries and we have more universal reporting of results, then PROMs will become a much more important part of how we deliver care. And they can be whether it's for minimally important clinical differences or substantial clinical benefits, how we measure how our joint replacements perform has to be better than what we've done in the past. However, the PROMs aren't perfect, right? I mean, still the ultimate, biomarker is the patient telling you that their knee is good or their hip is good. Um, the rest of the questionnaire maybe isn't relevant, but what we're learning about joint replacement is that expectations are probably a very important part of the process. So operating on the right patient at the right time in the recovery curve is probably more important than some of the technical aspects of the operation. And I think as we identify the subtleties of PROM reporting and decide at what level patients should be operated on, and I don't think this is going to be a universal number. I don't think it's going to be, less than 60 on a WOMAC or something like that. There's going to be differences by patient, individualized based on physical requirements and pain levels and things like that, which are difficult to measure, but which aren't impossible to discern. And that's where the clinical acumen comes in.
Mhm. Mhm. Absolutely. And that clinical acumen kind of glides right into the idea of patient selection criteria, perioperative protocols, and the like. With the rise of outpatient total joints, what which of those criteria or protocols do you think are most often overlooked when deciding who's a candidate? I understand that you've transitioned kind of more toward an administrative role, but I was curious for many people watching this podcast, they're surgeons or early career surgeons or trainees.
So the most critical part of qualifying your patients for outpatient arthroplasty is you. How you do the surgery, how efficient you are,
Mhm.
what other aspects of surgery you are using for your protocols. The patient is a separate issue. And we're rapidly showing that just about everybody can be done as an outpatient, unless they have such severe medical comorbidities that maybe you even consider not doing the arthroplasty in the first place. Patients are better off at home.
Mhm.
So if you don't have large amounts of blood loss, you don't have to give them large amounts of opioids, and they are clinically stable, they probably can go home. And we're pushing that envelope farther and farther every day with physician-owned surgery centers. Uh, so the surgeon skill and the ability to manage patients the day of surgery becomes, I think, the most important factor.
Mhm. Yes, yes, absolutely. And when deciding, what skills to impart on the next generation, you've trained generations of residents and fellows. What's a habit or a mindset that you've drilled into them that you think most directly predicts success as an academic surgeon?
Yeah, I think we sometimes forget that we're doctors. We're not technicians. You need to look at the whole patient. We also need to look at the socioeconomic factors. Not everyone has full support at home. Not everybody has the same wherewithal to care for themselves or participate in rehabilitation, etc. We need to identify which patients need help ahead of time so that they don't fail on their own at home. We need to remember that patients that seek you out for outpatient arthroplasty who want, the robotic implant, who understand the process, they're going to be fine,
Mhm.
right? They understand what needs to be done. There are, there's still a large group of elderly people that they trust their doctor. They'll do whatever they tell them to do. You need to be a little bit of a savant to see who's going to be at risk and who's going to follow those directions. There's a lot of underserved populations that may not be up to date with all of those things, and it's our job to make sure they are.
Yes, yes, absolutely. And then, kind of layering on to making sure that the patients are all right. You've often spoken about the economic pressures facing arthroplasty. I guess the way I'm phrasing this is going to be a leading question, but how do you see private equity and hospital consolidation affecting joint replacement surgeons and their patient populations over the next 10 years?
Yeah, let's not forget that private equity's in business for one reason, and that's to create value for their shareholders. That's not exactly part of the Hippocratic Oath. So, I'm not a huge fan of private equity. However, I am a huge fan of physician independence and the ability to create our own situation where we can administer care in a much more efficient way. So I have mixed emotions about private equity. I think the initial phase of private equity, where the investing surgeons end up, getting rewarded for their lifetime of hard work, is terrific. I'm a little skeptical about how that affects the younger surgeons who are part of those practices. There are some models where they are given some incentives and some options for continued employment. But remember, the reason you have a successful private practice is you're probably entrepreneurial and you like running your own ship and being in charge. You lose that with private equity, you become an employee. And eventually, private equity wants to sell that business for a second bite at the apple. So I'm not quite sure how that's going to work going forward. And certainly the entry of private entities into healthcare in general and for-profit medicine has not gone particularly well when you look at some of the larger for-profit chains and how they've affected hospital performance, et cetera. So, yeah, I guess I'm a little skeptical. Some models are better than others. I mean, I wouldn't condemn all of them. But it pays to keep your eye on the ball.
Yeah, absolutely, absolutely. And that kind of segues a bit into the idea of robotics. I understand that, at least on clinical rotations, what I've been told is that many private practices um, even avoid, or like private equity firms that own the practices avoid robotics because of the high, capital expenditures and even operative expenditures with, lots of disposables. And, other places prefer, the advertisement of robotics and being able to attract many patients. So, robotics and navigation are heavily contentious in the joint replacement space, and yet they're heavily marketed. In your view, what clinical endpoints justify adoption, and what evidence, be it even from, marketing and business perspectives, are still missing? I mean, from really a holistic standpoint.
Yeah, another excellent question. So robotics has evolved, right? When robotics was first introduced, it essentially was a navigation-driven saw, right? It cut the bones according to your preoperative plan and what you desired, with no consideration of soft tissue balancing. It has evolved to the point where you can do that very well, very predictably, and see what happens. Um, I did robotic unicompartmental knee replacement. Occasionally, I would do robotic um, total knee replacement for patients with severe deformity or hardware in place. But if you look at the outcomes of knee and hip replacement with robotics are not any better than manual
Mhm.
total joint replacement. Um, you were involved with a project looking at patient sentiments around those topics, and there really is no difference in the patient satisfaction either. However, very few of us go to get our car tires aligned and walk into the dealership and ask for the gray-haired guy who does it with his thumb up in the air and estimates what good alignment is. We like to use the computer. It's more exact. So although I think we have a very good operation in hip replacement and maybe a less good operation in knee replacement, but still outstanding, um, one can't escape the fact that if the cuts are made more exactly and the tissue is balanced more appropriately, it will lessen the learning curve for younger surgeons. And most younger surgeons are being trained on robotics. So there's no doubt that adoption will continue um, to increase. And I think eventually we will show that the outcomes should be better.
Mhm.
Costs are coming down for the robots. There's a lot more. They're more of an implant delivery system with, volume concessions. You don't really have to pay for the hardware. But having said all of that, I don't think the future is robotics. I think with the disposables and the large machines and the lack of portability and the linking of one device to one robot, it's probably not the ideal system. I think eventually there'll be some virtual component that's going to happen here, like a Top Gun headset connected to your instruments that will obviate the need for a big clunky robot in the room.
Sure.
And I don't think there's any major technology that's gone forward based on hardware that's successful over a number of years. It's usually the software that triumphs. So I think that'll happen with technology assisted joint replacement as well.
Mhm. Mhm. I find it very interesting, actually, that the future is not robotic. And, with the way you mentioned it, I'm inclined to agree. I mean,
Every
it's
single
huge.
manufacturer has a virtual arm,
Mhm.
um, and they're doing it in parallel. I won't mention any names in particular,
Sure,
but
sure. No,
they're
no.
they're very advanced, and I think the manufacturers see the writing on the wall
Yes.
because it's so much less expensive to do it that way.
Mhm. And really cost is, arthroplasty has become one of the most scrutinized specialties for cost and value. I do wonder, how should young surgeons balance their duty to innovation with the realities of policy and reimbursement and those other aspects?
Well, I don't think, listen, going forward, fee for service is not going to be the model of choice.
Mhm.
Certainly for CMS, we will be embedded in longitudinal care bundles. We will likely, for CMS and Medicaid, be involved in some ACO-like model that delivers that care.
Mhm.
Hopefully, we will lead those episodes, but that's not necessarily the case. So we will have skin in the game in providing cost-effective care. Um, for example, I did all polyethylene tibial components forever because they were cheaper and they lasted just as long. My survivorship was 98% at 18 years. They never got loose, right? They might have got infected, they might have broken, but they were fantastic implants. Um, Again, I won't mention manufacturers. Some were better than others. But when I went to another system, there was no difference for my economics in using modular versus all polytibias. And it's certainly easier to do a modular implant and has some benefits for revision situations. Certainly for teaching, it is too. So, getting back to robotics, why do surgeons want to use robotics, say, in an outpatient setting? They want to do cementless total knee replacements. They
Mhm.
want to do them quickly, and that the robot facilitates that. There's no cementing. They make their cuts. They bang their implants in. They don't resurface the patella. They go home. So maybe they do 7 cases a day instead of 5. That's economics.
Mhm.
Now, whether they think it's better or not, I can't comment. I'm sure it is better for the cementless surfaces to get a more pristine cut, but we haven't shown that either. So the data will drive the decisions, but I think training has already driven those decisions, and there's no doubt that we all orthopedic surgeons love technology, right? I mean, that's why we did this, right? We get to play with the best toys.
Yeah. Yeah. No, absolutely. And you know, I was also thinking about, playing with the best toys, but who on? And, many of your papers highlight disparities in arthroplasty outcomes by race and socioeconomic status and even geography. I was wondering, are there structural reforms in orthopedics that you think could actually close those gaps, or are those immutable kind of truths of medical practice?
So I'll tell you a little story. So when bundle payments started in 2012,
Mhm.
CMS's position was that if you have Medicare, you will receive the same care no matter where you are because you have the same insurance. There is nothing further from the truth than that. When I was in practice in New York and I was in Lower East Side of Manhattan, and people would not come from far up north, from Harlem, from the North Bronx to come down to the Lower East Side because that wasn't their neighborhood. That wasn't where their primary care doctor sent them. Even though we had openings, even though we accepted 52 different insurance plans as well as Medicaid and the exchange plans, some people just won't travel. So there are socioeconomic deserts where they don't get the best access to the best care. So therefore, the care is different. The new bundle payment program that's coming out, TEAM, tries to accommodate for that. It tries to keep patients in their same neighborhood and incentivize the under-resourced hospitals to keep patients there and give them the right care with the right equity. So CMS now realizes that just because you have Medicare insurance doesn't mean that you get the same insurance in Westchester County as you do in Harlem. So the best way to fix a problem is to identify it first. And I think we've drawn a lot more attention to socioeconomic disparities over the past 10 years than we had previously. And I think, no, I don't think it's an unsolvable problem. But we still haven't settled in this country whether healthcare is a right or a privilege. And, the insurance situation is divisive right now. It doesn't allow us to give everyone the same consideration because there's a lot of difference in access, there's a lot of difference in equity, there's a lot of difference in resources.
Absolutely. And insurance is really dictating a little bit more of practice than it used to. I was wondering if there are things that doctors have agency over that they're able to act to kind of increase their own operative independence. Do you have tips for future surgeons on how they can push back and start to exercise their own autonomy? Or is this a new reality that surgeons need to start to get used to?
Yeah, it's interesting. Like pre-authorization is a big problem right now with some insurance plans, especially some of the Medicare Advantage plans. And many of my colleagues will complain about it. I have to tell you, I never had a patient get denied surgery once you answered the reviewer's comments. Um, so I would advise young surgeons operate on patients who are indicated. Document, document, document. There are some pretty key phrases. We've written some papers about that. We wrote a recent paper about rack audits and what you need to include in the note so that the hospital and you get paid. Um, there are pretty simple rules for how this happens, and sometimes we don't follow them, and then we complain about the system. If you document the need for the operation and you document the patient's pathology and you document their level of disease, it's amazing how the very few questions get asked about that. But nevertheless, let's face it, the insurance companies and the audit companies, their goal is to deny 10% of the care, right? If even 90% of that denial gets eventually approved, they still saved, 1% of the bill. And in healthcare, that's a lot. So they try and put up fences, they try and make it difficult. Um, Again, if you operate in the right people for the right reasons, generally you're not going to have a problem. Um, if you're just concerned about volume and you don't consider the other aspects of care, then you may have a problem.
Absolutely. And what are your thoughts then about and this is my second to last question. I really want to be mindful of your time as well. What are your thoughts on the new allegations of AI auto insurance denials, which had come out earlier last year, I believe, where they were using AI to auto reject? Is that something?
Yeah, I mean, listen, I don't think AI is perfected yet. I mean, there's clearly a lot of learning that goes on with the models. Um, Maybe the AI is going to be more objective than the current reviewers who generally aren't orthopedic surgeons and aren't generally learned about what we do. Um, I think if the payers would work with us to find the right things to look for and the wrong things to look for, it might be a lot more effective. So I wouldn't reject AI out of hand because it might make this a lot easier as a system, which is pretty cumbersome right now. I know in New York, we would have one secretary for our phone calls and one secretary for our insurance plans. I mean, that's an enormous amount of work. So that's not an efficient system. Um, and I know that at one hospital that I've worked at, they wouldn't code necessarily appropriately for operations because they rather would get paid quickly than have a claim linger on.
Mhm.
So they would give the easiest code to get paid for rather than try and get everything that the surgeon or hospital should have gotten. So um, There are two sides to every story. If AI can make this more objective and more accurate by reviewing charts and getting stuff that maybe our coders and their reviewers don't see, I'm all for it. But it needs to be right. It can't be. We don't want to see it practice on us.
Yes, yes, absolutely. And, you know, my final question would be about EHR data integration. That's kind of the bedrock of being able to deploy those AI systems at scale. I was wondering if you saw any hints on the horizon or any, movement toward that kind of approach.
Another
Something.
excellent question. So again, without mentioning brand names, there is one current company that's maybe not the biggest one who has embraced AI quite a bit and
Mhm.
maybe on the verge of enabling AI to help with clinical decision making, to make the right call on medications or on care pathways, along with an integration in the ER. There are also add-on AI clinical decision-making tools which are coming
Mm.
and actually are already here and in practice. There are some legacy EMRs which maybe don't embrace AI quite as much and are trying to figure out a way to do it now. But based on their past platform, maybe they're not optimal for that. They don't have a lot of translational capability and it's just another plug-in module. So much like the iPhone wasn't the first, digital phone that was available, it was a later iteration that happened to capture the market. Perhaps the best EMR isn't quite out there yet. And there's no doubt AI is going to change all of medicine, right? I mean, remember, I used to walk around with textbooks to look up what I was going to do. When was the last time you looked in a textbook, right? I mean, yeah,
Never.
exactly,
Yeah. Maybe
exactly.
during anatomy lab when we couldn't get
Yeah,
cell phones out.
yeah. So things change, I mean,
Yeah.
even I changed, after in a 40-year career. So, um, your generation will be so much more advanced with these things. You'll be doing things 20 years from now that you have no idea about right now. And, with the advent of GLP-1s, with the advent of cartilage regeneration, with the ability to genetically alter some disease states, you know, maybe you won't be doing total joint replacement in 25 years. I don't know.
It'll be considered some barbaric approach. But
Yeah, much, yeah, much like pins and plaster, I think, I mean,
yeah, incredible. Thank you so much for sharing all these fantastic perspectives. And, I'm extremely grateful that you managed to make this podcast happen. And I'll be sharing this not only with the Georgetown Research Group, the Orthopedic Interest Group, but just people all over the nation. So very grateful that you were able to join.
well, you're welcome, Cameron. And everyone should know that Cameron's done some first-rate research over the years here, and he'll be applying for orthopedic fellowships and residencies. So, keep your heads up.
Absolutely. Thank you so much, Dr. Iorio.
Congratulations. Take it
All
easy.
right. This is Cameron Sabat signing off.